So we'll go through our slides together, point out some key information that will be on the exam, or at least what we remember to be on the exam. Uh, the Kahoots are in there for you to use. I will go back and change that question that was wrong into airborne precautions instead of neutropenia precautions because that was wrong. That was my bad. So to start off, immunity. Um, the immune cells within our body, you need to know B lymphocytes and where they come from, and T lymphocytes where they come from. Everything comes from the bone marrow except those T lymphocytes go to the thymus to mature, and the B lymphocytes stay in the bone marrow to mature. Um, Now it's kind of a nice kind of mnemonic or remembering tool. T for thymus and B for bone marrow. So as long as you remember that, it should be okay. And then some like little refreshers. Lymphatic system filters out white blood cells. Spleen stores white blood cells and platelets. Filters out the bad or old red blood cells. Um, the bad red blood cells are broken down in the spleen by the macrophages. It aids in the immune system. The spleen does by identifying microorganisms that may be causing the infection. I think on your worksheets you have to kind of describe or know the functions of each single immune cell. Um, Macrophages are the larger white blood cells that specialize in engulfing and digesting all the pathogens. Neutrophils are your first responders within the innate immune system. The natural killer T cells and B lymphocytes destroy pathogens from cellular mediated responses. So something is telling them to go target it. It is not the just um, initial responses like the neutrophils. Something is actually telling them what to do. The B cells are your antibodies, so that's your antibody response. These are targeted attacks as well, but your body forms these antibodies. Um, and the purpose of the immune system, is to identify self cells versus non-self cells. So if the immune system is dysfunctional, this is what results in autoimmune diseases and your immune system attacking your own cells. And so we'll get into autoimmune diseases later, but right now we'll talk about pretty healthy immune systems at the start. Okay, so this was part of that Kahoot. So I'll jump at the bottom, the artificial passive immunity. Anything passive is what you're being given. So um, this is the mother's milk, the antibodies from the mother's milk. Somebody is giving you that. Same thing with the antibodies from a transfusion or a blood transfusion. All of that is being given to you. You are not making those immune cells. As to active immunity, um, whether it's natural or artificial, your body is having to make those immune cells and make those antibodies. Um, so natural active immunity, it's you just fighting off an infection of some kind. You get something, you fight it off. Um, and then artificially active is vaccines. Um, and then passive natural is mother, and then artificial passive is blood transfusions or monoclonal. You will have to know these for your exam. 1000%. If I could guarantee anything, it would be this. Know the examples, know what they are, definitely on the exam. Infection assessment data, these are just things good to know conceptually. There's no way of knowing whether it's going to be on your exam. In a form, this will probably be on your exam. They may have a patient, give you a patient and their symptoms. They may come in with fever, enlarged lymph nodes, high white blood cell counts. If they had a skin infection, they'll have redness, drainage, warmth, swelling. The respiratory, they'll be coughing, sputum production. GI, it's diarrhea, vomiting, nausea, cramping. So all of that kind of indicates infection. If you're given a symptom that is related to infection, think and interventions and things to go with infection. Some labs and diagnostics. High white blood cell counts, you're worried about a current infection. Um, Semi-high white blood cell count can be inflammation. Low white blood cell count, you're worried about infection, which is mainly pertaining to cancers. Eosinophil and basophils are inflammatory response. Neutrophil, lymphocyte, and monocytes are all infectious. Uh, that was or should have been on your worksheet. It was on mine last time. Um, and I think it's an important thing to take note of for your exam, at least knowing the inflammatory responses markers. Very, very important will be on your exam indefinitely is cultures coming before antibiotic administration. So you need to have known there is bacteria growing before you administer antibiotics. And this is why is this important? Because you can get false positives, you can get ineffective medication regimens. In doing so, you will have some organ dysfunction if you're just administering a ton of antibiotics for no reason. You know, your kidneys take a hit, your liver takes a hit. It's just not good. And then you risk that bacteria becoming even more antibiotic resistant than it already is. So it's not worth it. It's not good. Um, and then sensitivity test tells what antibiotic would be the most effective in killing the bacteria that is growing. And this is where we switch from broad spectrum to specific antibodies. So we'll get those cultures, we'll get the sensitivity, and once we have collected those, immediately the physician will start a broad spectrum antibiotic. Um, and so that culture will come back, and then that sensitivity will come back, and then we'll bridge them from a broad spectrum into a specific antibody or antibiotic to better treat that infection. And then the ESR is typically done for inflammatory processes, but it can be done for infection. It's just quickly, it shows how quickly the red blood cells cell at the bottom of the test tube. Um, Maybe that definition may be given on your test. I think it was in your worksheets, um, but yeah. And then know the white blood cell ranges. Know the range with white blood cell count. I don't know. I don't think you need to know all the percentages and the ranges for neutrophil, lymphocyte, monocyte, eosinophil, basophil. But just to play it on the safe side, put it into a flashcard. Try to memorize it the best you can, because you never know. Precautions. I'll run through these relatively fast. This should have been covered first semester as well. Standard precautions that's used for everybody. Contact precautions. This is your gloves, gowns. Used for MRSA, C. diff, and VRE. Droplet precautions. This is where you have to wear a mask, but also gown and typically gown and gloves. I don't know. Typically, I don't. Some people don't wear gowns with this, but gown and glove as well. Influenza, RSV, mumps, rubella, and pertussis. And then airborne precautions, what we talked about earlier, that I need to go fix on Kahoots, is that N95. You want to wear an N95 or PAPR, and they need to be in a negative air pressure room. This is for varicella, tuberculosis, and measles. So, bridging off of airborne precautions into tuberculosis, which I'm sure you will get a question on your exam talking about um, patient has tuberculosis, what precautions do you use? I don't know if it'll be that straightforward, but go with negative, not negative pressure, airborne. So, typically seen in patients who live in very close quarters. This is your poor housing, homeless, jails, nursing homes, college dormitories, anybody with a poor immune system can't really fight that off, and poor nutrition. Symptoms that really stick out, I won't go through all of them, but the night sweats, the fever, and the coughing up blood, that is huge. That is a big indicator for tuberculosis. And then the diagnostic tests, which we've all done at some point before going into nursing school, is the Manitox skin test. We all know about the wheel. If it is more than the 10 millimeters, it is positive. Less than 10 millimeters, it is normal. It's false, negative. Um, it must be read 48 to 72 hours later. Quantiferon Gold is a definitive blood test It's a definitive diagnosis. Chest X-ray rules out active TB, and then a sputum culture is done after the chest X-ray um, for further confirmation of active TB, and is checked every 4 weeks for 6 to 12 months following a positive test result. So, cannot stress enough: put the patient airborne precautions. Uh, Isoniazid or isoniazid, yeah, we'll go with that. I do not believe, and I do not remember this being on the test. I remember rifampin being on the test, not INH. Uh, but there's a little educational piece right there for INH. Uh, so rifampin causes bad birth defects. We want to educate these patients on birth control for both men and women. Big thing is it can turn skin and urine orange. That's a pretty big thing too. Liver damage can occur when taking this drug. So watch liver enzymes. Watch for jaundice, clay-colored stools, and tea-colored urine. So they'll be on this medication for a bit of time, 6 to 12 months. After 3 weeks, they'll have to decrease their risk of transmission, and they'll be able to go out and socialize more. But for those 2 to 3 weeks, they will have to be socially isolated, um, and they will have to wear a mask at pretty much all times. Um, so you can see where mental health comes into play with tuberculosis. And then that prolonged usage, that prolonged time of taking medications, this is every single day um, for 6 to 12 months. It can become tedious, and then they can deviate because it's so long, it takes up so much of their life. So this can deviate the compliance and cause them to, it can cause worsening outcomes. So this is kind of your run-of-the-mill average treatment for most infections. Regardless of what infection it is. A culture of some kind, whether it's respiratory, wounds, um, GI, you can do a culture there. Urine, you can do a urine culture. Just want to figure out what bacteria is growing so we can better treat it. So we want to treat with antibiotic or antiviral or antifungal. Treat with fever with Tylenol, 4,000 milligrams or 4 grams max daily. Antihistamines. Ibuprofen is not antihistamine. What am I doing? Ibuprofen is an NSAID. Antihistamine can treat inflammatory symptoms. I mean, I guess NSAIDs can do the same thing, but kind of treat warm swelling and pain there. And then increase nutrients and hydration for anybody. They'll probably have decreased hydration, decreased nutrients, but we want to be increasing that for them. And then cleaning, dressing changes. Vancomycin has a very therapeutic window, so we want to draw troughs to figure out before their next dose, so we want to know their lowest level. If they already have a high level before their next dose, we do not want to keep administering the vancomycin because that will cause vancotoxicity and then kidney damage. So, just important side note there. If they talked about vancomycin in the lecture, it would be something to take note of. Gout. It's an overproduction of uric acid or under excretion. They form the crystals within the joints, causing that painful joint nodule there. It's an inflammatory response. It increases risk for vascular disease and blood clots due to the inflammatory process. Healthy diet is avoiding any foods high in purines. It's a very important note to take note of for the exam. Put it into a flashcard. There's foods to avoid there at the bottom of that picture. And then allopurinol. It's your main stage of medication for gout. If you're going to remember anything for gout, it's low purine diet, allopurinol. That's mainly like the two. You could use prednisone and NSAIDs to treat inflammation. Osteoarthritis. So damage to the cartilage. So the inflammation will cause deterioration of the bones and the joints. You'll get the crepitus, the swelling, the fusiform swellings of the joints. This is where you'll get those nodules or those nodes, the Herbin's nodes and the Bachter's nodes, Bockards. Um, Managements, big ones I can talk about here. You can read through them a little bit. PT, you want to do light exercises, very, very light, not heavy, strenuous exercises. NSAIDs and corticosteroids decrease that inflammation. That's great. Um, Sometimes they'll do a joint aspiration. That's something that could help them if they really wanted. Heat makes it worse, and then ice makes it better. So this is where it kind of differentiating with rheumatoid arthritis. Heat makes rheumatoid arthritis better, and ice makes osteoarthritis better. So this is where we jump into RA. So this is where our immune system, or goes out of whack. Um, Same thing with the rest, but this one especially. Attacks all the mucus cells within the body. So this is not just a joint problem. This is an everywhere problem, um, but it's mainly seen in the joints. So along with all the joint problems, it'll cause the dry mouth, the dry eyes, and the vaginal dryness. Um, and because it attacks the joints, the patho behind that is it destroys the synovial membrane, the synovial mucous membranes, therefore destroying the synovial fluid, causing what you see there. So something to take note of: low-grade fever, morning stiffness, joint pain, and joint stiffness, weakness or poor movements, I guess. You'll probably get a case uh, of a question in which it states all of these symptoms, and they may be like, okay, and they may throw in some labs, some elevated labs, which you'll see on the next sentence there. And they may go, okay, what is this? Or what are some good interventions for this? Um, so that ANA, or the anti-nuclear antibody, that lets us know there's an autoimmune disease going on. So that'll be positive. And then RA factor, C reactive protein, and then ESR will all be elevated, pointing to an inflammatory process, pointing to RA. Um, and then we want to treat or intervene with warm compress, prednisone, NSAIDs, DMARDs. Those are um, kind of your first line treatments there. Do take note, because this will be something also covered in third semester as well, but any use of a corticosteroid like prednisone will increase glucose levels, will decrease the immune system response, which is actually what we need in an autoimmune thing, in an autoimmune attack. We actually want a decreased immune system because it treats all of their symptoms and treats our disease process. But because we're decreasing our immune system, we're at risk for infection. So just something to take note of, something to think about. Methotrexate is also used for rheumatoid arthritis. We'll watch for kidney and liver, and they may need folic acid. And then Humira, that kind of goes with a little bit of the DMARDs, and that kind of DMARDs category a little bit. So um, it's just another thing that kind of suppresses the immune system and helps treat the autoimmune response. Systemic lupus, this is a widespread chronic systemic progressive autoimmune disease. So it affects the vasculature in your body. It can cause renal failure, mouth ulcers, and because there's renal failure, it causes that blood in the urine. That butterfly rash, that's huge for lupus. If there's anything on any test question, anything with butterfly rash, immediately go to lupus. No questions asked there, because that's a dead giveaway right there. It could also cause cardiac issues, endocarditis. Can cause severe abdominal pain, joint pain, pulmonary hemorrhaging. And then I added it twice. There's some alopecia, Raynaud's phenomenon, all the stuff I said. So 2 instances of signs and symptoms there. Diagnostics, same thing. The ANA will tell you if there's an autoimmune response going on. C-reactive protein, and ESR. The difference between these diagnostic tests with lupus and RA, there's not a whole lot. The only definitive diagnostic between the two would be that RH, that not the RH, the RA factor that we talked about with rheumatoid arthritis, comparatively to lupus. Both are autoimmune and both will cause all these diagnostics to be elevated. The only thing that kind of deviates is the symptoms in which the patient is showing, whether it is, um, um, well, I guess both cause joint issues. So what you see is a butterfly rash comparatively to maybe a low grade fever. Um, so this can kind of trip you up a little bit when they throw in diagnostic tests like this. But just know ANA, any autoimmune, C-reactive, or ESR, that's just any inflammatory process regardless. Um, so NSAIDs again decreases inflammation. Steroids decrease inflammation, actually decreases immune response, therefore decreasing inflammation. And then this anti-malaria drug, I won't even try to pronounce it for you guys, but yep, that one. It requires frequent eye checks. I think I remember it being on the test, so just take note of that. And then we'll get into GI. So this is kind of a reminder of what everything does. You can kind of read it for yourselves if you need a little refresher, but this is stuff that we talked about in anatomy and physiology, and then maybe a little bit in patho. So I won't go into a whole lot, but what I will say is I'll get into the pancreas stuff when we get to pancreatitis. Absorptions in the small intestines. If we have an issue with the small intestines in some way, we have issues with absorption, and then we'll have issues with malabsorption, or there will be malabsorption of some kind. Um, and then GERD, the length of which you talked about GERD, I don't know too much about, but there's a dysfunction in the lower esophageal sphincter, causing food and that acid to come back up and cause issues with the esophagus. So patients should be sitting up after meals. That's a good intervention to have. They shouldn't be lying down because all that acid is going to be just leaking into that esophagus. And so as we go into the next one, constipation and incontinence. There's quite a lot here, quite a lot of information. You can kind of uh, see what I've bolded, and you can take notes of what you want to. And I mean, some of this may be a little bit of common sense. I don't entirely know. It just depends on how much you know of constipation and incontinence of bowels. Um, so when it comes to constipation, none of these processes are normal, by the way. If there's a question of saying whether or not this is normal, I never want you to say it is normal because it might not be somebody else's. It may be somebody's normal, but it may not be another person's normal. So with older patients, it is common, but it is not normal to have either constipation or incontinence. Um, for older patients, they'll have decreased peristalsis, decreased nerve impulses to defecate, causing more fluid to leave the stool, therefore resulting in harder stools to push out, leading to constipation. Um, so there's a little bit of some physiology there, sort of patho there, I guess. If you have a decrease in water intake, if you're dehydrated, that means there's less water in the stool. So once it does reach the large intestines, um, all that water will be absorbed within that stool, and then it just makes harder stools very quicker along that tract, causing constipation. Any form of decreased peristalsis will cause the stool to be in the large intestines for longer, therefore constipation. That's why in opioid use within the hospitals, that's why it causes constipation, because opioids slow the peristalsis, slow those nerve impulses, um, leaving that stool in there for longer. Therefore, all that water is reabsorbed into the intestines and then making it harder to pass. So we give medications to put more of that fluid and reduce that surface tension in that stool to make it easier to pass. If there is constipation, there is something that can happen that's called fecal impaction. Uh, making it very hard to remove and making all that stool behind it to back up, and then that causes issues. Uh, if fecal paction occurs and there's no intervention, it can cause an obstruction, obviously, necrotic bowel, and perforation of the bowels leading to sepsis. Things to take note of that increase your risk of constipation or causes that could be contributing to constipation is aging, sedentary lifestyle, poor diet, lack of fluid intake, opioid use, spinal cord injuries, and MS. Some good interventions that are non-pharmacological: ambulation and drink plenty of water. Those are all great. And then pharmacological, you want to do laxatives, suppositories, enemas, stool softeners, anything to help a stool pass. Incontinence, we talked about this in the Kahoot, but it can cause social isolation. It's not a normal part of aging. Um, Contrary to what we talked about with contrary to incontinence is laxatives. If there's a urge incontinence, which urges the sudden need to defecate, laxatives could help because you initiate those own defecations on your own with the administration of a laxative. Metformin does cause diarrhea. Avoid caffeine, alcohol, lactulose, fatty foods, and any certain food that makes like incontinence worse. Devices to help. I remember there being one question, and it was a weird question, and that's why I remember it, um, of either nerve stimulant or a magnetic ring helping for incontinence. Um, so just take, if they didn't talk about it in their lecture, maybe you don't have to worry about it. Maybe they took that out for this year, but um, it is something that might help incontinence. And then educate in a high fiber and adequate fluid diet. With this diagram, with this picture, all I want you to take note of here is if it's right upper, think liver and gallbladder. If there's any questions saying patient coming in with right upper quadrant pain, immediately go to liver or gallbladder. If it is upper middle, think peptic ulcer, pancreatitis, even GERD, but probably more pancreatitis if I were to give you a test question, or if Skradsky was going to give you a test question, it would more likely be liver, pancreatitis, or it'd be one of those. I just put left upper in there for spleen, but at no point in this lecture was there anything talking about spleen. Your main pathology is either pancreatitis or cirrhosis, or even cholecystitis, so it's either going to be right upper or upper middle. So just take note of that. Diagnostic imaging. There's a lot here. I will blow past these. I will tell you what was on our exam. So stool that is white or chalky, that is a good educational piece for somebody doing any sort of barium test. So this goes for the upper GI barium swallow study and the lower barium enema. They will both have white chalky stools. So educate your patients on this being a normal process. EGDs, they help define those peptic ulcers or those stomach ulcers. If they find an ulcer uh, and the patient is having black tarry stools, I mean, that coincides with one another. So an ulcer in the stomach, all that is bleeding, all that blood is being digested by the intestines, therefore causing black tarry stools. And just know long-term NSAID use is what causes those ulcers. So we never want to encourage a patient to take long-term NSAIDs. We want to treat a patient's pain better if they're chronically taking NSAIDs. We don't want somebody taking ibuprofen every single day until they die because they will have so many peptic ulcers. Stool test. Main thing to tell about this is it tells you whether or not you're bleeding in your GI tract. We want to tell patients not to take NSAIDs, aspirins, or blood thinners because it worsens the bleeding. Avoid vitamin C, weirdly enough. I think that was on the exam back when I took it, was a vitamin C, or educate somebody to avoid vitamin C prior to doing a stool test, something like that. And then just don't do this if they have hemorrhoids or they're on their period because it interferes with the stool test, obviously, because the blood is not necessarily coming from the GI tract. So it makes false positives, really. Uh, Colonoscopy, um, this is another big educational piece. I mean, all these are going to be like educational piece questions. Uh, Definitely on the test for sure is this colonoscopy question. Uh, you want to encourage clear. I put clear twice. Clear, clear. So for the driving home, strictly clear, clear liquid diet. No red or purple diets or foods or liquids. Uh, and then just for any of these procedures, they need to be NPO at midnight, but colonoscopy, they need to be NPO at midnight. They may be dehydrated, weak, confused. They may have low electrolyte levels, so something to note there. But definitely on the test is clear liquid diets, no red or purple liquids, and then NPO. That's a very good test question to have on this test. Colorectal cancer. I'm gonna be honest, I don't remember this being a whole lot on the exam. Take that with a grain of salt because they change the test every single year. Um, but there's not a lot of good information here. Um, Colorectal cancer, it's cancer of the colon, abdominal pain, weight loss, changes in stool pattern. We see the changes in stool pattern because the cancer is obstructing the intestines. So as the stool tries to pass, it'll skinny up and make it very like pencil-like, trying to get past that tumor. You'll see blood in the stool because that cancerous tumor will be bleeding. It will be vasculature, so it will be bleeding. Um, and you may even feel the mass within your abdomen as you're palpating the abdomen. And then, weirdly enough, it'll decrease vitamin D levels. Stages to colorectal cancer. I don't know if you necessarily need to know these, but um, I would I would take note of it at least. It matches a lot from what your last unit's exam was with cancer when we talked about cancer there. Just talking about the metastasis of it, and then the involvement within the lymph nodes. So as long as you're able to connect that with the stages, you should be okay. Risk factors is family history and age above 50, smoking, obesity, and lack of exercise. The big ones is family history and above 50. Um, and then early prevention is key. Low fat diet is pretty good. High fiber diets, good vitamin D levels, and lower red meats is a good prevention method. And like I said, early detection is best. Stoma care, you guys talked a lot about this in tech class, so I'll kind of blow by this one as well. Um, know your assessment for stoma. So they should be beet red, moist, and have even a small amount of bleeding is okay. Being post-op for a couple of days. They should not be black. They should not be blue. They shouldn't be excessively protruding. They should not be dry. They shouldn't be like excessively bleeding, almost hemorrhaging, and then they shouldn't be dusky looking. Um, yeah, that's really it. Know those key assessments, what's normal and what's not. And then you've got your care down there, so mild soap, dry skin before putting on the bag, a 1/8 of an inch bigger than the ostomy. Learned that in tech class. Nothing should be inserted into the stoma. And then I'll skip past the NG tube. This is really for post-op if somebody did have a stoma surgery or in, intestinal resection. So I'll kind of skip past that one because I don't think that's going to be on your test. Some additional nutrients. I put these in here. I don't remember if this one's on the exam either, and wasn't a whole lot of information about the additional nutrients. Um, NG tube, PEG tubes, jade tubes, they're all able to supply nutrients, especially seen in patients who have swallowing issues. So this will be a good connection, a good test question, and good connection between what you learn with strokes and what you learn with CVAs and stuff like that, because those patients will have swallowing issues. So they will have an order for an NG2 placement or a PEG tube placement. Um, so just something to take note of there. They could link the two lectures up together. And then TPN, um, they need to be given through central line or PIC. Monitor those glucose levels every 6 hours. They'll probably have a fat emulsion along with the TPN, and then that tubing needs to be changed every 24 hours. You want to monitor weight, albumin levels, electrolyte levels, and glucose levels because those are all pertaining to nutrient levels. Cholecystitis. So this is what we talked about with it's inflammation of the gallbladder, mainly linking to gallstones or cholelithiasis. Um, you want to look for the five F's. So female, fertile, 40, fair skin, and fat. Fat is more BMI and just rather the intake of fatty foods as well. Upper right quadrant pain, jaundice, nausea, vomiting, steatorrhea, and fever. So, like what I talked about with the upper quadrant pain, if any test question comes in with upper quadrant pain, you want to think either cholecystitis, cholelithiasis, or cirrhosis, or hepatitis. But those all kind of link up together um, with this. Um, you'll have a positive Murphy sign and Bloomberg sign. So Murphy sign is you take in, hold a breath, and then you palpate upon that right subcostal area. And if that patient feels pain when they're touching that gallbladder, that's a positive sign. When pressure is applied, so Blumberg sign is a rebound pain upon palpating the site of pain, wherever they're feeling that pain, which is most likely going to be that right upper quadrant, so rebound pain there. You'll see an increase in white blood cell count, leukocytes, bilirubin, and liver enzymes, all linking to inflammatory processes, but also trying to fight off. There could be an infection within that gallbladder as well. So, um, but mostly it's gallstones. So lithotripsy for breaking up the gallstones. Surgery to move the gallbladder could occur. Laparoscopic procedures to fix the issue going on can occur. And then just education is avoid fatty foods because um, that bile is supposed to help break down that fatty food. And if the gallbladder can't do that, then it, it won't help break down that fat. I threw this in there because a lot of stuff conceptually goes in with liver, um, and it's important to know the functions of the liver and then connect those with the concepts we're learning and what we're implementing within our interventions. So, uh, liver removes toxic byproducts, and it also removes medications. So, if we have cirrhosis or we have issues within the liver, and we have a buildup of we'll have a buildup of toxins like ammonia, which leads to the hepatic encephalopathy. If we have cirrhosis, we are really, really monitoring our medications in which we are administering because uh, overdoses on medications can occur. Um, they will have a lack of um, vitamin KADE, which is pretty important, especially vitamin K, which is intended for clotting, which you'll see at the bottom blue there. It regulates the clotting factors, so that's big. That's why we put the patients probably on a they'll be thrombopenic, so we put them on bleeding precautions. They help break down and release like glucagon and like good energy stores. So you'll have patients have fatigue and issues with like energy and glucose production because of the lack of metabolizing nutrients. And then they lack the liver produces the proteins in which we need, so albumin, which is why we see the ascites. So if we have low albumin levels, all that fluid that's in our vascular system will go into the tissue, leading to edema and leading to things like ascites. So all pretty important things. This is a really good picture, really good. If you understand the functions of the liver, you'll understand the concepts, and then when you understand the concepts, you'll understand the interventions in which you are implementing. So good liver diagnostics things you'll probably see at clinical and doing your clinical paperwork. Elevated ALTs and ASTs. So elevated levels of ALT or AST or bilirubin will be indication of poor liver functions. And then, like I said, you'll have low albumin levels because it's not producing enough albumin. And then low clotting lab diagnostics, so PT and INR. So those will be elevated because our clotting factor is all messed up. Hepatitis, it's just the term itself is inflammation of the liver. We really connected a lot to the viral infection that you get with um, like Hep A, Hep B, Hep C, Hep D. That's what we really link it to. But people who are alcoholics and who are progressing into cirrhosis will get this chronic, they'll get hepatitis because hepatitis leads into cirrhosis, which then leads into something like liver cancer, which you see that diagram shows down there. Um, or not, more or less, the cirrhosis will lead to liver failure, needing a transplant. Um, so yeah, cirrhosis. So um, chronic liver damage leading to the scarring and the liver failure. Mainly caused by alcoholism, but it can be progressed from the state of hepatitis, like the um, viral hepatitis. Um, so a lot of the signs and symptoms in which I'm going to describe is based on those functions within that liver. So jaundice is the buildup of bilirubin. Our liver is supposed to take that bilirubin that's in our blood and push it back to, I think, the gallbladder, or I think it's supposed to break it down and just like store it. But if our liver is dysfunctional, that bilirubin is going to stay in our blood, and that bilirubin is then going to go into our tissues, causing that jaundice. Petechiae. So you'll see little bruises or like rash-looking things, like bruises that look like rashes actually, and that's just because of the low clotting factor and that thrombocytopenia. Lack of protein synthesis causes low albumin, which then progresses into ascites and edema. So we'll then require a paracentesis to remove all that fluid. And if all that fluid is in your abdomen, pushing up on your diaphragm, you'll have poor oxygenation. So something to know there. Ammonia buildup will cause encephalopathy, confusion, and fecal breath. Portal hypertension will cause the esophageal varices. The I don't even know the flapping hands. The you could try to pronounce that, but yeah, that term with the flapping hands. Usually in conjunction with hepatic encephalopathy, and then the tea-colored urine. So again, bleeding precautions. Your bleeding precautions are all there. You could put that into a flashcard. Electric razors, no aspirin, no big needles, so only small needles. Decrease needle sticks in general, and then just protect them. Put them in full precautions. We don't want them to fall. Additionally, address any fluid or electrolyte imbalances, and then you want to assess them neurologically for any encephalopathy. Varices. That picture up there is very, very good. It's very important. I would memorize it. Propranolol prevention. I wouldn't be surprised if they use propranolol in your test. And then I wouldn't be surprised if they used octreotide in your test either, because they used it for our test. And it's a really good picture to utilize. Um, they 1000% use this in our test. So beta blockers, lower pressure. If they are not bleeding, we want to use propranolol. Be very, very observant with the test question. It will say the patient is bleeding or the patient is not bleeding. Um, and that drastically changes the treatment option you choose. Um, so, bleeding, vasoconstrict, use one of those three meds: the teriparatide, the somatostatin, or the octreotide. Um, if they're not bleeding, use a beta blocker like propranolol. And then the treatment options are down there. They did not test this. They did not test it on us, or at least I don't think they did. But they're really cool to see if you see it in clinical or able to see it at work. If a blue tamponade is really cool to see. I've never seen banding, but um, they do that. And then never heard of a sclerotherapy, but I guess they also do that. But a balloon tamponade is really cool to see. So, um, yep, those are treatment options for varices. Hepatic encephalopathy. Um, this is the buildup of ammonia. Ammonia will pass the blood-brain barrier and will cause it will be very toxic to the brain and its brain function. Um, you want to give lactulose if there's a buildup of ammonia, because that lactulose will bind to that ammonia and will be released in the fecal matter when you pass stool. Um, this hepatic encephalopathy can be a cycle for somebody with cirrhosis and liver failure, so they may have like little episodes of confusion in developing this hepatic encephalopathy. And the reason this is because uh, those who have cirrhosis will be chronically on lactulose. Somebody who's on chronically on lactulose does not want the side effects that goes with lactulose, which is diarrhea. They just hate that and they don't want it, and it's embarrassing if you have diarrhea, and it's not great. So they'll skip their doses of lactulose, and then they'll get extremely confused, and they'll have all these symptoms of hepatic encephalopathy because of the ammonia buildup, and this is what occurs our endless cycle. So other medications that could be tried is rifaximin and neomycin. Those also decrease ammonia levels, but not as effectively as lactulose. So there you go. And then you got a cute little picture there of I am confusion. Um, pancreatitis. It is inflammation of the pancreas. It is mainly due to a structural abnormality, or it is also due to alcoholism as well. A gallstone can get dislodged in one of the pancreatic ducts, leading to that obstruction, and so those pancreatic enzymes cannot leave the pancreas itself, causing those enzymes to do nothing but break down the pancreas. So, gallstone blocked up, all those pancreatic enzymes, those amylase, those protease, and those lipase will just chew up at the chew up at the pancreas, leading to dysfunction and tissue breakdown. So acute will see big lab changes, and then chronic will see little lab changes due to the compensation. The Cohen sign. If they didn't talk about this, you don't have to worry about it, I guess. But it's a bluish discoloration around the umbilicus, accompanied by pain. Malnourishment is huge because of a loss of digestive enzymes. They cannot break down foods like carbohydrates, proteins, and fats. Um, there's a loss of insulin, loss of fat soluble vitamins, there's persistent pain. Um, so, all things to kind of know there. Interventions: educate on alcohol, like with getting off of alcohol and alcohol cessation. Decrease fats in the diet, monitor glucose levels, avoid stress, monitor those supplements and electrolytes, administer opioids for pain, administer those pancreatic enzymes, so amylase, lipase, and protease, and along with insulin. And then Whipple, I would definitely know the definition of a Whipple. This was in our exam, and I think a good portion of people did get it wrong. So just know the definition of what a Whipple is.
Alright, now we're gonna move into the sensory neural. Strokes. So an ischemic stroke is a blockage of blood flow. Everything past it is not getting the blood and oxygen that it needs, so you lose function to that part of the brain. Know that AFib increases the risk because the heart's not pumping right. It creates clots. These clots pass through the blood vessels basically, and they can create that blockage. And a hemorrhagic is bleeding. This is when the vessels weaken, and hypertension increases the risk because it thins the vessels. Then basically it breaks open, it ruptures, and bleeding occurs. And then again, no blood flow moves beyond that point because it's leaking out. The ICP, you need to monitor in these because of the bleeding. SCBA, you need to know your different symptoms depending on which side of the brain it's on. So the left brain, you guys can read these lists here, but for the right side, there's a little thing that you can use to remember. Right and rowdy both start with R, so I think that people with right side deficits don't know, they're not aware of their deficits. So they're rowdy, they're impulsive, gonna deny their illness, things like that. Some ways you can prevent strokes from occurring. You need to manage the blood pressure and the hypertension. If they have AFib, they need to take their antiplatelets and anticoagulants. Manage your diabetes, your cholesterol, decrease your stress, stop smoking, of course, that goes for everything. Manage your weight, good diet, exercise. Most of these go with everything. The antiplatelets for AFib and managing your blood pressure are big ones here. And then always stop smoking. These are signs that you can look for to determine if a stroke might have happened. You'll want to memorize this because it just makes things a lot easier, but like is their balance off? Is their vision off? Is anything asymmetrical, whether that's their face, their arm strength? Are they having speech difficulties suddenly or slurring? If these things are occurring, then they need to check them out for a stroke. Neuro assessment. I'm sure you guys are pretty good about this at this point. Here's just a list of things. Be aware of your Glasgow Coma scale that was on this exam. I believe that she had us grade some symptoms that she listed. I'm not 100% sure about that, but I kind of think she did. This was on your Kahoot. I feel like there was a question about this too, so maybe be aware of the different levels of consciousness and what order they go in. If not, you'll need it later to be able to describe things. For your neuro assessment, obviously you're going to do LOC, your mental status, you're going to check your cranial nerves, your pupils are huge, reflexes are huge. Are they posturing? Are they not? Different postures mean different things. The cerebellum, so you got your Romberg test, your gait, you can do your heel to toe test, check their balance.
physical, that has to do with their mobility and injuries that they've had, physical injuries, intellectual or developmental, your genetic abnormalities like Down syndromes and Fragile X, autism. And then there's mental illnesses that affect your cognitive function, schizophrenia, bipolar, OCD, really any type of or I guess that's pretty obvious, mental condition. When you're caring for adults with disabilities, use simple terms, call them by their name, try to give them independence and autonomy. Don't make them feel belittled, obviously. And dementia versus delirium. Dementia was on your Kahoot. It's a symptom, not a diagnosis. It is a symptom of Alzheimer's or sometimes delirium. Dementia, though, is it's like a slow decline of their mental status over a period of time. Delirium is a rapid onset of the symptoms. Delirium is often reversible, but dementia is not. So for delirium, you want to reorient them since it's short, reversible. For dementia, they're declining. They're going to keep declining. So in the beginning, you want to try to reorient them, give them antidepressants. But once it gets to a point, they're not going to remember or understand. So the best thing you can do is validate them. This will be a question on the exam. I remember this one. To diagnose dementia, there's these two little tests we do. There's a mini mental state exam, and that stages the disease. And then there's the short BLESS test, which is shorter, and it covers like orientation, memory, concentration. Alzheimer's, it produces dementia symptoms. It's because of atrophy of the brain tissue, and the microtubules unravel, they twist, and then the functioning can't happen normally. The amyloid plaques break the connections to the nerves so that communication between the brain and everything can't occur, right? And then there's no true diagnosis of this because we can't diagnose it until after death, and then they'll do an autopsy and you can look at the brain and you can see the atrophy. So basically we just look at the symptoms and things like that to diagnose it. Some of the risk factors are Down syndrome, women. I feel like that was on the exam, women. Family history, obviously, head trauma. That's supposed to say trauma. To decrease the risk, healthy diet, exercise, things that stimulate your brain, puzzles, reading, engaging materials, lower your stress. And then these are the same assessments, the mini mental exam and the short BLESS test, and then also the clock test where they have them draw the clock, and sometimes they'll be all wonky. I'm pretty sure she showed a photo in class. And then you want to stage the disease. There is no true treatment, so you just want to slow the progression. You're going to keep a structured environment. Consistency helps them remember things. You're going to want to stimulate their cognitive function. You're going to want to give them puzzles and things like that. Promotion of self-management. Try to keep them completing their ADLs as much as they can themselves. Antidepressants. I don't know if these meds were on there, Namenda and Aricept. Those can help to slow it. And then reorient in early stages, validation in later stages. This should be highlighted because this will 100% be on there. And then for your interventions, they're a huge safety risk. They might not know where they are. They might try to run, keep their bed alarms on, brails up, make sure you can ID them, make sure they have some form of ID on them, especially if they're like not in the hospital, and then try to help them communicate. Staging Alzheimer's. For the longest period of time, they maybe just like have a couple things off, like short-term memory loss, and it gradually gets worse over the years until they can have deficits in everything, even like their vision. Actually, this might have been a question too. I would be familiar with this chart. Parkinson's is a gradual loss of the substantia nigra. The dopamine transmits signals through the brain to control your movements, and acetylcholine is responsible for the contractions of the muscles in the movement. So basically, what happens is there's a loss of dopamine, which causes the acetylcholine to be higher and cause these symptoms. The risk factors I feel like were on the exam: people over 50, people who have been exposed to chemicals and metals, family history, men, but it is idiopathic. We don't have a true thing that causes it. These can just increase the risk. Symptoms: mask-like face, that was 100% on the exam. Dysphagia, muscle rigidity, the shuffling steps, and the tremors. Those symptoms all are like the cardinal signs of it, so I would be familiar with those. Also know that you need 2 out of 4 of the cardinal signs to be diagnosed with Parkinson's. To diagnose it, you're going to run labs and diagnostics to rule out other things, look at the cardinal signs that they have. There's not really a diagnosis, like a cut and dry, they have Parkinson's, they don't. You got to look at a bunch of different things. For treatment, you're going to basically try to keep their quality of life and their ability to complete their ADLs and things like that. Balance, functions, they're going to need PT and OT. They're going to lose their function gradually. So keep their ADLs as much as they can. Eventually, when it progresses super far, they're going to have speech issues. They're going to need different things like special aids that we talked about. Brain stimulators can help. Different meds. These are some of the meds. The levodopa, carbidopa, that's going to be on the exam because it causes on-off syndrome. Just be aware of this whole thing right here because that will be the exact question. MAOB inhibitors preserve the dopamine, but they cannot drink any alcohol with this or a hypertensive crisis could occur. Requip restores the dopamine and helps release more, and then antimalarials decrease the side effects that occur with it. Then some interventions, you're going to want to maintain their safety and mobility. No throw rugs because they can slip on it. Their caregivers, she hit really big on this. It can be really draining for caregivers and take a toll on them, so you want to support the caregiver too. There's adult daycares that they can put them in to have like a little break for the day. Staging Parkinson's. Usually they don't get a diagnosis until they're in stage 2. These are the main points, but diagnosis usually is stage 2. Stage 4, they start to lose a lot of their mobility and function, and then at stage 5, they can't walk, can't stand, they don't remember things, they hallucinate. Things really start to decline 3 to 4 though. Migraines. They're a chronic neurological pain. Some risk factors is family history in women. Different things can trigger it, like the weather changes, life, stress, different foods, lights, sleep deprivation, all kinds of things. Some symptoms are going to be your nausea, vomiting, pain. One side of the head can hurt or one side of the neck, stuffy nose, watery eyes. Be familiar with what an aura is. People get auras before their migraine hits. They can see halos, vision changes. Sometimes for me, usually I'll get like a halo and then it'll just black. So some people smell things. For treatment, you got to determine the cause. So all those triggers, try to see if those could be your triggers, and then basically you just remove those from your life. There's acute treatment, there's meds, there's a lot of meds you can do. Ameritrex, Tylenol, triptans, ibuprofen, Zofran to keep the vomiting down, antidepressants because sometimes depression and stress causes the migraines, propranolol, Tomax, gabapentin, nerve pain, sleep, rest, massages, all kinds of stuff. Be familiar with pharm and non-pharmacological interventions. And then there's CGRP blockers. These are your highly potent vasodilators. So be cautious in cardiovascular conditions and wound healing. And then these are some examples of it. Basically, my mom takes these. You take it when you start to get like the aura, and it's supposed to shut it down, or at least that's how she uses it. But some people take these every day. The issue with these is they're newer and they're very expensive, and insurance does not like to give them out. Chronic pain is common in older adults. They've got more wear and tear on their body. It's a common cause of disability. It causes substance abuse because these people just don't want to hurt. And then requires a support system to manage the pain. You're going to have a team of people, your physician, psychologist, sorry. They can supply you with medications to try to decrease symptoms of like depression, anxiety, things like that might be contributing. PTOT, and then the nurse, of course. Chronic pain can lead to anxiety of patients, and then they might need those meds that we were talking about. Ask them what their pain is, and then always remember the pain is always what the patient states. Assess their baseline, because these people that have chronic pain have pain all the time. So something that might be a 7 to somebody else might be like a 4 to them, but they're still in pain. And then treatment's going to be massage, PTOT, antidepressants. We don't want to treat with opioids and gabapentin because obviously we don't want anybody on opioids long term, and gabapentin too. It's for nerve pain, so I mean we just don't want those people consistently on that. And then here's your pain assessment. Normal vision changes. Our eyes do change and our vision does change as we age. The muscles weaken, the cornea flattens, which can kind of blur our vision. And then we get dry eyes because of the decreased tear production. This increases risk of infection and corneal abrasion. Our eyes don't dilate the same that they do when we're young, which leads to poor night vision. The elasticity decreases, they harden, which leads to cataracts. And then we have poor up close vision because we lose the ability to accommodate. So for these patients, it's important to tell them they need to go see the eye doctor regularly. They're going to assess the acuity of their eyes, their fields, the deficits, and the need for interventions. They might need glasses, they might need surgery, meds. Cataracts is common but not normal. She likes to use the word normal a lot, so know that. Basically, a loss of water causes the protein fibers to compact, and then when they clump together, you can't see through them. Risk factors is older age, diabetes, smoking, sun exposure, hypertension, family history, people that are overweight, people that drink alcohol. And the symptoms, obviously, you can see it. They have trouble at nighttime seeing, blurring, color changes, double image. To diagnose it, you're going to do an eye exam and a vision test. And then to treat this, you're going to have to surgically remove the cataract and then keep eye drops afterwards to make sure it doesn't dry out again and reform. Glaucoma is also not normal but common. So there's this fluid that floats inside your eyes, and basically with glaucoma, you can see the proteins floating in the fluid. There's two types. Be familiar with the two types. Open angle is when the drainage angle is open but partially clogged, and then it can't drain right. So the pressure of the eye increases gradually over time, and then that pressure on the optic nerve is what kind of messes with your vision. Closed angle is an emergency. It's acute. It's triggered by something. The iris bulges forward and it blocks the angle so no fluid can drain. Risk factors, family history, over 40, diabetes, hypertension, history of ocular problems, corticosteroid use, a lot of things. Symptoms is going to be gradual vision loss for that open angle. It's going to be sudden for that closed angle, and that's the emergency. So remember that. High pressure, they might feel that. There's going to be red veins visible in their eyes sticking out. Nausea, vomiting. To diagnose it, you're going to need to go to the doctor and get it checked. If it's a closed angle and they suddenly lose their vision, obviously they're probably going to go to the ER and find that out. To treat it, you want to reduce the pressure in the eyes with the timolol. For a closed angle, of course, you're going to have an emergency surgery. So surgery. It's basically a needle in the eye and it's going to drain the fluid. Macular degeneration is a central vision loss caused by deterioration of the central retina, and that basically sends the images up the optic nerve to the brain, and then the brain processes it. There's two types. Again, know the types. Your dry is going to have yellow deposits forming. It's called drusen, and then that causes the macula to dry. It thins and loses function. Wet is acute. It's an abnormal blood vessel behind the retina that causes a bleed, and then a blister that moves the macular. Symptoms, you're going to have blurred vision and then a loss of your central vision. Risk factors is lighter eye color like your blues, older age, family history, vessel damage, diabetes and hypertension, smoking because these things damage your vessels, and then a B12 or a keratin deficiency. Treatment-wise, there is no treatment for the dry macular degeneration, unfortunately, but you can increase antioxidants, give vitamin B12 and keratins to try to help. And then for dry, inject avastatin to clot the bleeding vessel. Sorry, that should say wet. Always remember that acute is a bigger issue than a chronic issue. For people that have visual impairments, they're a huge safety risk because they can't see, and they can fall. So put these fall risk interventions in place, the bed light, the bed light, bed low to the ground, etc. Large print so that they can see. They might need glasses. Put cotton balls on their call light so they can feel the call light and they don't have to try to get out of bed to come get you if they need something. Verbal or video instructions because they might not be able to read very well. And then eye drop education is huge for these people. They can't see, so they need their eye drops in a location that they are not going to mix it up with something else. Tell them how to take it. They're going to place it in the conjunctival sac and then close their eyes. This should have been on the next page. This is for your ears. For hearing loss, it is expected as you change or as you get older because there are changes like longer hair in your ear, your wax gets drier and it compacts together. It affects your hearing, the elasticity, and the tympanic membrane. And then there's a couple types of hearing loss. Your conductive is when volume is too quiet, and then your sensorineural is when it's distorted. You can have a mix of both. And then this is your earwax impaction. Symptoms are going to be muffled hearing, dizziness, pain, fullness of the ears, like a foul odor. To treat it, you're going to do mineral oil irrigation, ear scopsy. Teach these people how to take their eardrops. So that was on the page before, tilt their head back, pull their peanut up, and then pull it back, drop the eardrop in, tell them to lay on their side, don't move for 5 minutes, and then they're good to go. Hearing devices are made special to the patient. They are very expensive, so not everyone that needs one has one. If they can't, there's an amplifier. It's right here. It makes sounds louder so they can hear. And then a question on there was what to do, like how to speak to patients that have hearing deficits. So you're going to face them, you're going to enunciate words, you're going to slow down when you're talking, use a lower pitch because sometimes it's just that higher pitch that they have difficulty with. And then make sure you get their attention before speaking, reduce the stimulation in the room, things like that. And there you go. This is the Kahoot we did at the beginning. I believe it's the neuro one. And then here's my Quizlet from the semester. Does anyone have any questions?